Hi, good afternoon to everybody. Thanks for listening to this and looking into this webinar. As you can see, the title is Testosterone Therapy for Women, Evidence-Based Recommendations. There is a long-standing, somehow, controversy about the importance of androgens for women. I think it was brought up with the concept of female androgen insufficiency and the famous Princeton consensus statement already published in 2002 by a lot of very eminent endocrinologists and gynecologists. And they were describing a situation and a syndrome almost, which was characterized by diminished sense of well-being, persistent unexplained fatigue, sexual function changes, vasomotor symptoms, bone loss, decreased muscle strength, changes in cognition and memory. And if this cluster of symptoms was associated with a t-value at or below the lowest quartile of the normal range of reproductive women, and if at the same time women were estrogenized and still having these symptoms, then it was considered that they would suffer from androgen insufficiency, from a lack of testosterone. In the same publication, there was this decision-making algorithm, which basically repeats what I have discussed with you before. Does the woman have these symptoms? Are there alternative explanation? Is the woman sufficiently supplied with estrogen? Does the woman have laboratory values consistent with the diagnosis of androgen insufficiency? And does the woman have specific treatable cause for androgen insufficiency? So when we look at it in a broader sense, we can say that the challenge is that testosterone for women certainly has very different aspects and qualities. Androgens may have health and quality of life promoting actions on the brain, sexual desire, bone, muscle, skeletal symptoms, LLDL decrease, increase in free fatty acids. It may also have negative actions on health and quality of life, as we all know from PCO, skin, hair, body image, voice deepening, clitoralomegaly, and there is this somehow overlap that androgens can have positive and negative actions individually. And we do not yet really know the absolute ratio in the individual woman, and that's probably the big challenge. Now, to look into the scientific background of androgen therapy, we had a global consensus position session, which was then published as a statement on the use of testosterone therapy for women. As you can see, this panel consisted of people representing different societies, EMAS, ISSM, Federation Latinoamericana, almost all the societies involved in women's health care and in this issue of testosterone therapy. Now, the aim of this global consensus position statement was to develop recommendations. Recommendations regarding the measurement of testosterone, female sexual dysfunction, and endogenous androgen levels. Recommendations regarding systemic testosterone therapy for postmenopausal women in doses that approximate physiological testosterone concentrations for premenopausal women, based on findings from meta-analysis of placebo comparator controlled, randomized controlled trials, and finally, the clinical care of postmenopausal women. I would like to discuss with you the chapters 2 and 3. I think these are the most important ones for our practice. Now, For the first part is recommendations about the systemic testosterone therapy made with physiological doses. The issues that were looked into in this meta-analysis was, what do we know about testosterone therapy in breast health? What do we know about testosterone and metabolic effects in cardiovascular health? What do we know about effects of testosterone on well-being, mood, and cognition in postmenopausal women? What do we know about effects on testosterone on the musculoskeletal system? And what do we know about testosterone therapy of sexual dysfunction? You will see that the focus finally will be on the treatment of sexual dysfunction, and we will look together into this issue by discussing possible androgenic side effects of testosterone, serious adverse events, and what can we actually offer and treatment recommendations. Let's first go for the blue part, the general issues about testosterone in general health and well-being of women. What is known there? As you can see, the meta-analysis shows these forest plots where you can see on the right side those study results that favor the comparator, and on the left side from the one, those who favor testosterone. And you can see that actually the available data from this meta-analysis look that the available data suggests that short-term transdermal testosterone therapy does not impact breast cancer risk on the level 1, grade A. But if you go back a little bit to these studies, quite a number of them are short-term studies. We do not have enough long-term studies. But taking all together, we can say that for the moment we have insufficient data to assess long-term breast cancer risk. Now, what about differences between oral transdermal testosterone regarding lipid metabolism? And as you can see, there is actually really a considerable difference between oral and transdermal in the meta-analysis, where you can see that the oral therapy indeed does look like having a negative effect. So the conclusion was oral testosterone therapy is associated with adverse lipid profiles, with negative effects on HDL cholesterol and LDL cholesterol levels, and is not recommended. Studies of non-oral testosterone therapies, percutaneous and injectable, in doses that approximate physiological testosterone concentrations. This is always very important. Those concentrations which we have in premenopausal women, and they have shown no significant adverse effect on lipid profiles over short term. What about cardiovascular events in general? You know, deep venous thrombosis. What do we know about stroke, acute myocardial infarction, mortality? And here again, as you can see, the comparison does not indicate that there is an increased cardiovascular mortality, but we have even found other results. Testosterone therapy has not been associated with increases in blood pressure, blood glucose, or HbA1c levels, again, high grade. A non-significant trend for an increased risk of deep venous thrombosis has been seen with testosterone therapy. However, the role of concurrent estrogen therapy in possible venous thrombotic risk cannot be excluded. If you go back here, you can see there is a tendency, but some of the studies had a combined therapy. Limited data preclude assessment of the effects of testosterone therapy on myocardial infarction or death, but insufficient data. Randomized controlled trials of testosterone therapy have, and that is important, excluded women at high cardiometabolic disease risk. Most have included women taking concurrent estrogen therapy, and all have been of relatively short durations. So recommendations regarding the effect of physiologic doses of testosterone in postmenopausal women on cardiovascular health are not generalizable to a more at-risk population or long-term therapy. So again, still limited information, but what we have seems to be that the physiological therapy seems to be safe regarding cardiovascular risk. Now, on the positive side, of course, there are studies and clinical experiences which indicate or seem to indicate that women who take testosterone feel better and they have a better cognitive function. The meta-analysis of the study showed that there is insufficient evidence to support the use of testosterone to enhance cognitive performance or to delay cognitive decline in postmenopausal women. We just don't know. Available data show no effect of testosterone therapy on general well-being. What we have measured with mood questionnaires. Testosterone may improve well-being in premenopausal women, but data are inconclusive. Now that's the difference, that it may well be that in premenopausal women, where women experience again a decline of testosterone, which of course starts earlier in the mid-30s, that they may have a positive effect on mood. What is also important, as we know that there is this issue of perimenopausal depression, that it doesn't look like for the available data which we have, but there is still a lack of studies that, for example, addition of testosterone or testosterone alone would show an effect on depressed mood. Musculoskeletal system, very important. Again, here we do have, of course, the biological and physiological action of testosterone on muscles. But unfortunately, really well-done studies are lacking. Of those studies that have reported musculoskeletal outcomes, the number of included participants has been small. All participants are taking concurrent estrogen therapy, and no studies have been made in women with osteoporosis. As what we know right now, but again, there is not much material regarding studies. Those data which we have do not support an effect of testosterone treatment on bone mineral density at the spine, total hip or femoral neck at 12 months. So bone mineral density, there is no proof. And there is no statistically significant effect of testosterone administered in physiological doses on lean body mass, total body fat, or muscle strength, because that was always an issue also in fracture protection, that testosterone may prevent falls. But here it is clear that we need clinical trials to better know the possible potential which is there. But for the moment, there is no proof that you have an important positive effect. So finally, we come to the issue of sexual function. And here, of course, the analysis was not easy, because when you look in the studies, you have so many subgroups, and you have different outcome measures. You have menopausal status, surgical, natural, perimenopause. You have concomitant estrogen therapy, yes or no, oral or non-oral. And unfortunately, in sexual medicine, you don't have objective data, objective measurement. You have patient-reported outcomes, which are usually reported as questionnaires. Here, I've mentioned some of them. We can go briefly through it to summarize the forest plots. And as you can see, systemic testosterone therapy leads to a statistically significant mean difference in the increase of sexually satisfying events of 0.85 per week, so almost one satisfying sexual event more in the testosterone group compared to the other group. And this is in surgical and natural menopausal women taken together. In surgical menopausal women, the difference is more pronounced and is statistically significant. You can see in natural menopausal women, it is transgressing 1. So there is a certain lack of significance. But if you take all together, then you find an increase of the events. So the events by sexual events by menopausal status regarding the premenopause, you can see that here there is a possible beneficial effect, but further studies are needed. Again here, a forest plot comparing the way of the estrogen application, whether there is estrogen application together with testosterone, whether it's oral, whether it's not oral, and you can see that there is a significant mean difference of sexual satisfying events, almost again the same, 1 per week, in women with different forms of estrogen therapy. Interesting enough, we always had the impression that the oral therapy would have a more negative effect in the sense of reducing free testosterone via SHBG, but in these studies it did not show up. Here, the comparison between those who were asked, those studies which were looking into sexual distress, the FSD, which is very important, asking women, now your changes in sexual life, does this distress you? Would you want to be treated? And you can see again the group surgical menopausal, natural menopausal, surgical and natural menopausal. And you can see here, there is a statistically significant reduction of sexual distress, which indicates a therapeutic effect. And this distress clearly is on the left side. It does not transgress 0. So this is level A1 evidence. And I think this is an important result. Here we have the different aspects of sexual function measured in the different questionnaires when women were asked about desire. Again, you can see surgical menopausal, natural menopausal, surgical and natural menopausal. Again, in the meta-analysis, in the combined studies, a beneficial effect on desire, which is statistically significant. So we have more sexual satisfying events, we have less distress, and we have increased desire. So we put that all together, and regarding sexual function and dysfunction, we can say that testosterone therapy in doses that approximate physiological testosterone concentrations of premenopausal women exerts a beneficial effect on sexual function above the effects of placebo comparator therapy, including increases of an average of 1 satisfying sexual event per month, increases in the subdomains of sexual desire, arousal, orgasmic function, pleasure, and sexual responsiveness, which I didn't show you, but all these aspects were significantly improved together with a reduction in sexual concerns, including sexual distress, as I have shown you in one of the slides. Because the majority of studies reporting on sexual function recruited women assessed as having low desire, hyperactive sexual desire disorder, or generalized female sexual dysfunction. These recommendations cannot be generalized to other subtypes of female sexual dysfunction or women without sexual dysfunction. That is just the point that when we treat patients with sexual dysfunction or women with sexual dysfunction or postmenopausal women, we really have to look also into other aspects of contributing to their sexual health or to sexual dysfunction. Now, the recommendations, and that is something which is important because in practice, it seems that a lot of testosterone applications are made in the context of sexual function, and applications are made with injectables, pellets, or formulations that result in supraphysiological blood concentrations of testosterone. We do not know. There is not enough studies, not enough evidence, and of course there is concern that supraphysiological doses may have effects which we would have to control for. So regarding physiological doses, we come now to this further issue when we talk about treatment of sexual dysfunction, where we have seen there is a place treating with physiological dosages. What do we know about possible androgenic side effects, serious adverse events, and what does the practice look like? So this is the second part. When we look at androgenic effects, there is acne, there is alopecia, there is clitoralomegaly, there is increased hair growth, there is voice change, and already from this forest plot you can see that there is no significant increase in all these androgenic side effects, taking into account that it is with physiological doses. We concluded the systemic testosterone therapy for postmenopausal women in doses that approximate physiological testosterone concentrations for premenopausal women is associated with mild increases in acne and body facial hair growth in some women, but not with alopecia, clitoromegaly, or voice change. You can see that major changes in acne were not observed, but in those patients with mild acne, there was a tendency towards mild acne and small increase of hair growth. Now, when we look into serious adverse events, again, the two groups and the forest plot, serious adverse events, cardiovascular, cancer, everything that was considered leading to hospitalization or was considered from the researcher a serious adverse event. Testosterone therapy for postmenopausal women in doses that approximate physiological testosterone concentrations for premenopausal women is not associated with serious adverse events. So from the other studies which we have already mentioned, it is important when we perform treatment of sexual dysfunction in postmenopausal women with testosterone therapy that regarding cancer risk, the studies that have been shown that short-term transdermal testosterone does not impact breast cancer risk, but it is important to mention that we do not know about long-term. As I showed before, again, this is also true for the testosterone therapy for sexual dysfunction. The oral testosterone therapy is associated with adverse lipid profiles, while the non-oral testosterone therapy does not show these negative effects, at least over short term. So you can see already there is a clear tendency to say, yes, testosterone therapy for sexual dysfunction in postmenopausal women is an evidence-based therapy, it should preferably be done by non-oral way, non-oral therapy, and for the moment, it would be to a certain degree time limited, because long-term studies are lacking. So what can we do in the situation where we do not have really a specific drug, especially a specific transdermal drug made for women studied in the context of sexual dysfunction, as we had with a testosterone patch, but which in many countries is no more available. So what happens now in many countries, and the task force concluded that it is okay, but it is an expert opinion, where an appropriate approved female testosterone preparation is not available, off-label prescribing of an approved male formulation is reasonable, provided hormone concentrations are maintained in the physiologic premenopausal female range. So here you can already see that if you use, for example, testosterone or androgen preparations, it is really recommended to control testosterone levels. And the expert opinion is that any testosterone preparation that results in supraphysiological concentrations, including pellets and injections, is for the moment not recommended. Although we know that this happens frequently and that there is an uncontrolled practice in many places which has a negative impact, which we don't unfortunately know exactly about the amount of problems. Now, as you can see, I showed you that the studies are usually not long-term. So we had the impression that we should recommend that should a trial of testosterone therapy be given for HSTD, a baseline testosterone concentration should be measured before commencement with a repeat level 3 to 6 weeks after treatment initiation, so that you are sure that you are in the physiological range. And which is also important, patients should be monitored for their clinical response to treatment and assessed for signs of androgen excess with a serum total testosterone level every 6 months to screen for overuse. Because that is, of course, also regarding the compliance, one of the issues. Compliance can go in two directions, non-use, but overuse. And I think this is also important, if no benefit is experienced by 6 months, we believe that treatment should be ceased. We also were discussing the issue which is very frequent now, and this is the compounded bioidentical testosterone therapy. We believe that it cannot be recommended for the treatment of SHTD due to the lack of evidence for efficacy and safety. We think there should be an equivalent preparation which is authorized. In the absence of an approved available product, if a compounded product is needed, the compounding pharmacy should be compliant with purity of active pharmaceutical ingredients and good manufacturing practice to meet industry standards for quality and safety. Now, this is something which refers, of course, to the pharmacies that produce these bioidentical preparations. And again, doses should be limited to achieving testosterone concentrations in the physiological premenopausal range. Big issue regarding preparations, other androgenic preparations, and you all know that DHEA is frequently used. And from a biological point of view, there are arguments because there is this age-related decline in DHEA, and DHEA as a precursor steroid hormones, of active steroid hormones might be interesting. Again, the problem is that we do not have enough studies. Those which we have regarding systemic DHEA did not show a significant improvement in desire or sexual function in postmenopausal women with normal adrenal function. Of course, it may have a strong effect in Addison's disease. And the group had the impression that it cannot be recommended on an evidence-based level for women with HSTD. In the absence of vulvovaginal atrophy, vaginal DHEA has not been tested regarding sexual function in general. And for example, the question, can you treat loss of desire or hypersexual desire with vaginal DHEA, where some studies have shown effects on desire, but this was made in patients with vulvovaginal atrophy. So I conclude, the international panel concluded the only evidence-based indication for testosterone therapy for women is for the treatment of low sexual desire and combined sexual dysfunction, with available data supporting a moderate therapeutic effect in postmenopausal women. There are, for the moment, insufficient data to support the use of testosterone for the treatment of any other symptom or clinical condition or for disease prevention. But that means we don't know, we have insufficient data and we need more data. There may be a potential, but it has not been proven yet. So thank you for your attention, and we can discuss, and I'm glad to answer questions.
Thank you, Dr. Bitzer, for such a wonderful presentation. And now for the Q&A session, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar control panel. Okay, Dr. Bitzer, well, actually we have a lot of questions that the attendees have been submitting during your lecture.
Okay.
Okay, so we will start.
Yeah.
Can testosterone be given to patients who had BSO for BRCA gene positive?
There is no data about this. We have tried to look into the issue of patients with breast cancer risk, and for the moment, I think this should not be given because, as you all know, transformation of testosterone into estrogen and the different aspects of this action on the breast tissue is difficult to predict, and I think this should not be given to these women.
Okay, our next question. What do you think about bioidentical testosterone, pellets or bioidentical transdermal?
Yeah, well, I agree with the group that we do not have good studies about the bioidentical. I think the whole enthusiasm about bioidentical hormones, in my view, lacks a little bit of the logic that whatever preparation you supply to make it working, and this is also true for synthetic or pharmaceutical produced steroids, it can only be acting when it interacts with the receptor. And the receptor seems to respond the same way. At least it has not been proven that the receptor, estrogen receptor alpha and beta, for example, respond different to bioidentical from synthetic hormones. So for me, it's a bit, maybe I'm wrong, maybe I lack information, but unfortunately, in my view, these basic studies are not available, and the clinical trials are not available.
Okay, the same attendee who asked the question says, in Argentina, we don't have female doses of testosterone gel, transdermal. We use the male doses in artisan doses, 50 grams of testo, 1% per week, distributed in 2 or 3 times a week.
Yeah, this is very frequently used also in my country, and as you are saying, it is a dosing, an updosing way where you have to control the levels of testosterone. But this is a way which is frequently used. I know, for example, also in other European countries, especially Portugal, the colleagues from Portugal report that this is very popular, and obviously also in South America. It seems that some of the problems is that women may have a tendency, especially maybe younger women, to overdose. But this is just a concern which was mentioned by the colleagues that were in the panel, in the expert panel. But if I may say that, it seems that there is a new preparation coming, which is specifically tested for women with female dosages of a transdermal female androgen. It seems to be, well, I don't know whether it's already in some of your countries available. It's not available in Europe yet, but it seems to be produced in Australia. And we are looking into that, forward into that, whether we get good studies and whether we get this preparation which is really made and controlled for women.
Okay, our next question is, testosterone assays may not be accurate and predictive of symptoms. When to measure this on test replacement? Yeah, well, this is very true. Of course, that there is not a clear correlation between symptoms and levels of testosterone. So I think we have to distinguish 2 moments or 2 phases. One is when at the time of diagnosis, where you look for the symptoms that could be related to low testosterone, and where you then make a determination of the testosterone levels. And I agree with the colleague that the practice now is not necessarily that the patient must have this very low testosterone levels to be a candidate for treatment, because obviously the impact of testosterone is due to differences like it was before, and we don't know like it was before when we measure it at a certain point. So it may be really the decline, the relative decline, which is more important than the absolute level. So I think the symptoms should predominate, and then of course the control, that if you give that you don't get into supraphysiological dosages. All right, thank you. What is your opinion for Tibolone to treat HSDD? Good point. I agree with you that we did not include that in our analysis, because Tibolone, as you know, is not a testosterone-only therapy. So the therapeutic effects of Tibolone probably are the combined action of its estrogenic property and its androgenic property. But when it comes to treatment of postmenopausal women with sexual dysfunction, especially with low desire, it is proven to have a therapeutic effect. But it's not testosterone therapy. It is a specific menopausal hormone therapy,
which has proven to have a positive effect on sexual function. Evidence-based.
Okay. Our next question is, in older women who no longer have VMS, can testosterone be used alone, provided that GSM has been treated?
What was the disease? I'm sorry. What?
In older women who no longer have VMS. VMS.
Vasomotor symptoms. Sorry. Yeah. Mm-hmm.
Yes. Can testosterone be used alone, provided that GSM has been treated?
Yeah. This can be done. Again, because it has been shown that testosterone, there were studies when we still had the patch, showing that testosterone therapy alone also was active, but these studies were mainly more in premenopausal women, in perimenopausal women, but when the treatment does not, the indication for the treatment of HSTD in postmenopausal women does not demand that the patient has vasomotor symptoms.
Okay. What starting dose of testosterone would you recommend, and what incremental dose?
Yeah, well, that's a difficult question. I cannot. Well, to be honest, I cannot answer that. I think the best evidence which we have is, of course, the Intrinsa patch, and if I remember well, that was 50 microgram. But maybe I'm wrong. I'm sorry, I don't. But this is I think the dose which we would try to use, and also in new studies and in the development of female preparations, because that has been proven. The Intrinsa patch has been proven to be effective not only in overrectomized women but also in natural menopausal women.
Okay. We have many questions, and many of those are submitted via chat. If you could please submit it via the chat box on your Zoom dashboard, that would be best, and your question will be missed. Okay. Our next question. Did you say that testosterone is contraindicated in women with a history of breast cancer?
Yeah, I think for the moment. Oh, sorry. Hello?
Oh, it's okay. It's okay. Perfect.
Sorry.
We can hear you.
I'm dark. You can hear me? You can hear
yes.
me? Yeah.
Yes, perfect.
Right. Yeah, I think for the moment it is contraindicated. We do not have any studies, and we certainly would be concerned about the uncontrollable transformation.
Okay. Our next question is, how long does it mean short-term treatment?
Short-term means basically 6 months. And I think what we would really need in the future in the studies would be, sort of intermittent treatment. I'm sure that, there is some evidence in other studies that it may well be that after 6 months, regarding also receptors, regarding the rather complicated physiology of sexual response and sexual desire in the brain, that the effect is going on without treatment. So I think there are biological and psychological and sexological reasons to make studies with intermittent treatment, which I think would also be in the interest of women, because many women, we saw that with the patch, do not like sort of a endless treatment for sexual dysfunction, and that is why the acceptability also of the patch was not so high.
Okay, our next question is, well, it seems more difficult to me to control physiological levels using male testosterone than using compounded with lower concentration. What doses do you suggest?
I don't understand.
It seems more difficult to me, says the attendee, to control physiological levels using male testosterone than using compounded with lower concentration. What doses do you suggest?
I mean, the premenopausal dosages are defined, and obviously the colleague says that with the bioidentical you will not be in danger of getting higher dosages. I don't quite understand.
Okay, we will go with the next question.
Yeah. Mm-hmm.
In COVID pandemic, how are you managing to check test levels at 3 to 6 weeks? Can it be postponed to 3 to 6 months?
Yeah. Well, that's a very good question. As this treatment is sort of a, how can I call it? It's not a standard treatment. It is made in the situation that we do not have a standardized female testosterone therapy preparation. And in this case, where you cannot control, I think it is, if you know the patient, if it is a patient whom you know personally and you know about also any possible risk factors, I think it would be feasible to prescribe a very low dosage to start with and see whether already a very low dosage of testosterone, where you're not in danger of getting into supraphysiological dosages, is effective. When it is not effective, I think I would not want to do that at distance. I think because we, as I said before, it's not a, we are sort of practicing medicine in uncertainty.
Okay, our next question is there a role for testosterone therapy in osteoporosis management in postmenopausal women?
The studies until now say no. It is not, I mentioned that in the first part of my talk, that you did not have enough clear studies having such an important impact on BMI, and not such an important impact on musculoskeletal symptoms, because of course osteoporosis itself is one thing, but what we really are targeting is the fracture risk at higher age.
Okay, well, we still have some questions. Women often experience peri-postmenopausal hair loss. How about testosterone treatment for these women for HSDD?
Yeah, well, that's a problem. I think this is one of the issues which in recent years has somehow disappeared. I don't know exactly why, but we do have women where in the menopausal transition, the relationship between very low estrogen and maintenance of androgens may actually lead to a well, I wouldn't call it hyperandrogenic state, but to a predominant to a predominance of androgens. And you know, many years ago we had menopausal preparation with cyclotyrone acetate for these women who developed in menopause hair loss or additional hair at the chin or at the breast. And I think these women, I would not treat them with testosterone. I think when these women, postmenopausal women, obviously, or in the transition, they would be for me a candidate for tibolone. Tibolone. Mm-hmm.
All right. Is there any point in measuring baseline levels if patient has had a BSO? Her levels will not be measurable.
Yeah, no, there is no reason, except you have the impression that it is an adrenal tumor. And, yeah.
Okay. Are the risks for androgenic side effects higher if the woman uses testosterone alone without HRT?
The studies do not show that. As I showed you the one slide where you could see that the effects on sexual desire were the same in transdermal and oral testosterone. In transdermal and oral estrogen therapy, combined estrogen therapy. So it doesn't look like that the possible effect of estrogen on SHBG would counteract really the therapy with active testosterone.
Okay. In cases of patients with premature ovarian insufficiency on HRT, who also have low sex drive, can they have testosterone replacement like Androfem 1 cream used in Australia long-term till age 15?
Yeah, I fully agree. I mean, I was mentioning this preparation, but even in those who, even in patients where we don't have the preparation, I think it is quite important that we find some testosterone replacement. Yeah. Mm-hmm.
Okay. Does treatment with spironolactone for hair loss typical in menopause cause low endogenous testosterone levels?
No, not to my knowledge. It's acting directly on the receptor, if I'm correct. But I wouldn't. No, I don't think that you would have a measurable decrease in testosterone. No. Mm.
Okay.
More a competition at the receptor, as far as I remember. Yeah.
Okay. Among all of these questions, we have a lot of messages saying congratulations to you for your excellent lecture, Dr. Bitzer.
Thank you very much.
Okay.
So, but I must say, I hope I could also show that there are many things we don't know. We have to be modest still. Yeah.
Okay. So continuing with a few more questions that we have. If it causes no CVS harm, can it be given to patients with cardiovascular disease?
Again, the first part of the question, sorry.
Now I lost the question. Let me. If it
causes, it's about cardiovascular risk patients, is it?
Yes, if it causes no CVS harm, can it be given to patients with cardiovascular disease?
Yeah, we don't know. That's the problem, that all the studies have excluded women with cardiovascular risk. I mean, I mentioned that in one of the conclusions of the group, that we do not know about effects in women with cardiovascular risk, and until proven otherwise, I think we would not recommend it. Hello?
on terms of safety, do you consider using estradiol plus testosterone is better than using testosterone alone?
Regarding cardiovascular safety or
no, in general
No.
of testosterone treatment on terms of safety?
No, I don't think so. No, I don't think so. That it is. The question was whether testosterone alone would, in terms of safety, be less safe than combination
with estradiol.
Yeah, no, I don't see a difference there. No.
Okay, what is your opinion about vaginal testosterone or DIA in vulvovaginal atrophy? What does the task force recommend?
Yeah, the task force did not. There was one mentioning that the application of, in that case, the ATS local vaginal in cases of vaginal atrophy has shown some effect on different aspects of sexual function. I showed you that on one of the slides. Unfortunately, it was a little bit fast, but that does not prove that local VHES can be used to treat low desire in women without vulvovaginal atrophy. The issue was that the main symptom is vulvovaginal atrophy with dyspareunia, and that by treating this locally with the ATS, with progesterone in that case, you get not only improvement of the vaginal atrophy and also reduction of dyspareunia, but when you use FSFI and other measurements, you also find improvement in other domains. But the explanation for the moment looks more like this is just the secondary effect of improving vaginal health. And then you improve also, the sexual well-being.
Well, a follow-up question. And what about applying testosterone in the vulva?
The testosterone receptors in the vulva, or what?
Exactly, yes.
Yeah.
If applying directly, I understand.
On the vulva.
Exactly.
Wow. For treating what? For treating low desire, or?
Well, that's not defined. So if you please can give more information, so we go to the next question.
Okay.
If PTS symptoms of HSDD have not improved with HRT, can we add testosterone?
Yes, I think so. I think this is not unfrequently the case that symptoms improve, like vasomotor symptoms, also sleep may improve, or even irritability may improve, but low desire sort of remains, if I may say so. And I think this is an indication of a trial with testosterone to see whether this part of the biopsychosocial complexity, whether the hormonal part is an important one. As you know, there are numerous other factors that affect the desire of postmenopausal women. We always insist in sexology that it should not be that we shouldn't only focus on hormones, but there are a lot of different other things: life stress, relationship, body image, etc. So I think it should be in the context of good sexual counseling, but it is what we quite frequently do if we have the impression that the hormonal component may be important.
Okay, and one of our final questions, when you mention evidence of short-term safety data, what time period do you mean? 2 years? Longer?
No, it's usually up to, well, the longest seem to be up to 1 year. Yeah.
Oh, and we have our last question. In the studies using testosterone for HSSD, sorry, any of them use applying to the vulva? That was the last question.
I see what you mean. No, there is no, to my knowledge, no.
Okay. Is testosterone indicated only for low sex drive and no other indication?
No, I mean the issue is that when you look at the studies, one issue, one outcome which is reported by the FDA is satisfying sexual event. And that also certainly has to do with arousal, with receptivity of the body. And it may well be that also in arousal disorders, and this has been shown also in studies. But what happens frequently, in these studies, you have desire, you have arousal, you have orgasm, you have pain as the main symptoms, and they are all at the same time evaluated. And sometimes you cannot easily distinguish which is the hen and which is the egg, so to say. But from a physiological sex or physiological point of view, I think it would also be reasonable. You would have a good reason also to treat arousal problems.
Okay, well, it seems that every time I say that was the last question, we receive one more. What is the percentage of androgen side effects? Is it 5-6%?
Well, if I remember well, but here again, I would have to see these 6 or 7 randomized control trials. As far as mild to moderate acne is concerned, and this slight hair growth, I think that was between 6 to 10, I think it was below 10%.
Okay. And finally, can testosterone be used in perimenopausal women?
There is no proof that it has, regarding sexual function, that it has an effect. But as I mentioned before, it might be interesting to use it in the context of perimenopausal mood disorders or depression. But until now, the studies do not prove. There is a tendency, but as I showed you, the statistical significance is not reached. But there is a tendency, and we would need further studies. And personally, I have the feeling that it is that in some women it will have an effect.
All right.
In some perimenopausal women, yeah. Mm-hmm.
All right. So now it seems that we do not have any more questions. Thank you so much, Dr. Bitzer, for answering all of these questions. Would you like to leave us with any final thoughts before we end this webinar? Yeah, well, as you may know, I'm a sexual medicine physician also, and it is really, it was my pleasure to work with this group on all these issues, and I think it is really important that we understand the importance of testosterone for women, and that we really look into possibilities to help women therapeutically who suffer from low testosterone. And at the same time, as I mentioned in one of my comments, when it comes to sexual dysfunction, we should always have a good counseling session, because even if the testosterone is indicated and important, the compliance is much better if you have really done a good sexual history and good sexual counseling. All right, so This concludes the webinar. Thank you again so much, Dr. Bitzer, for your presentation and all the attendees for being here today. Have a great rest of the day.
Thank you. Bye-bye.